All right, diuretics do what? They make you pee. That's it. What do diuretics do? Make you pee. All that's up there is just the keywords for the electrolytes. So like your keyword for mag is muscle. Calcium's keyword is it is heart with a little bit of muscle, right? Potassium's keyword is heart. Sodium's keyword is brain. Good, good, good. All right, so diuretics. Why would I need to make somebody pee? But if they can't, kidneys aren't working. Maybe, but you can't force a bunch of fluid on kidneys that don't work. So who would we need to get rid of a bunch of fluid? Heart failure, hypertension. Okay, so hypertension, there's only two ways to lower your blood pressure. You can either make them pee out fluid, or what's the other way? Yes, but like how? So you can either have them pee out the fluid, or what's the only other way to lower somebody's blood pressure? What do the vessels look like in hypertension?
Oh, they're constricted, so you're going to want to
Vasodilate. All right. So in order to decrease blood pressure, usually we have to do either vasodilate or get rid of fluid. The drugs have to do one of those two things. You with me? Okay. So diuretics are used to treat either hypertension, okay, heart failure, because in heart failure, we know they get a lot of fluid retention, right? Or edema, right? Because it's going to help you to get rid of that extra fluid. You with? What three electrolytes is the kidney responsible for excreting? Potassium, chloride, and sodium. That's important because if you're making somebody pee, most of these diuretics are going to cause you to lose all of those, and that's a problem, right? All right, so hold on to that. For all diuretics, and any time for this entire module that we're giving anything that alters somebody's blood pressure, okay, you have to take their blood pressure before you give it. Okay, and you have to hold the drug if their blood pressure goes less than 90/60, because at less than 90/60, what's going to happen to your patient? Yes, what happens if they're too hypotensive? That's what we're. Yes, they could go into shock. So if I go and check a patient's blood pressure, it's 88/50, and then I give them a diuretic, what's going to happen? Yeah, you're going to bottom them out. They're going to go into circulatory shock, and yeah, they probably will eventually code because they have no blood pressure left, right? So you hold it for less than 90/60. Now, I'm going to just throw this out there right now. Diuretics don't usually affect heart rate, okay? But for this whole entire module, you're going to hold any cardiac drug for heart rate less than 60, okay? All right, so those are your protocols. Before you give a diuretic, you need to look at their potassium levels, because if a drug is making them pee, then we know most of them are going to make you get rid of. So I want to check the potassium first to make sure I'm not bottoming them out on that, or they're going to get massive dysrhythmia. Not tacky, y'all. Massive dysrhythmias. Okay. All right. And then what is the best indicator of fluid balance? Daily weight. Now we're still going to watch urine output if they're on a diuretic, but the best indicator is daily weight. All right, so this is how you're going to use the diuretic sheet, okay? So on the diuretic sheet, these three up here are true diuretics. You see this big black line?
Yeah.
Okay, this one underneath is considered a diuretic, but it acts completely different, so that's why I like this one separate.
Okay.
So if you want to, even you can fold it like this for a while to get your mind used to these three, and then this one is a total exception to the rule because it works differently, okay? All right, so we're going to start with the thiazides. What you also need to know for each of these drugs is who we use them for and if they're weak or strong, okay? And these are going to go in order. If I fold this back, these are going to go in order. Weak, kind of weak, strong. So you can tell like how much it's going to drop their blood pressure, how much you really have to look at electrolytes. You understand?
Yeah.
All right, so the first one is called our thiazides. The drug, we call it HCTZ because the actual drug name is hydrochlorothiazide. Nobody has time to say that, so we call it HCTZ. It is weak, okay, but that's good. We want to give a weak one at first because I don't want to bottom anybody out when I first treat them for hypertension, right?
Yeah.
Highlight, it is the first drug of choice for hypertension, for especially if they're African American. If there's a race, something on here, they're probably going to test you on it. Okay, because there are some drugs when you give to certain races that it can be very harmful, and you need to know that. Okay, so this would be the first drug of choice for pretty much anybody, but especially if they're African American. Hydrochlorothiazide works very well for African American patients. How does it work? Oh, sorry. Also, while we're doing this, I want y'all to get this sheet out right here and put it right next to your chart. Okay. And as we go along in each of the drugs, you're going to look and see which parts of the nephron that it works on. Okay, and that way you can kind of see, because it is testable where these work on. And I put them in little clouds so you don't forget. Okay. All right. So HCTZ blocks the reabsorption. Now, what does reabsorption mean? Because I had this totally wrong in nursing school and it always confused me. What does reabsorption mean?
To absorb is to go into the
So
bloodstream.
to like pull it back in. So if it blocks that, then it's just letting it go out. You're just letting you pee it out. So it blocks the reabsorption of sodium and chloride in the DCT. What is the DCT?
The descending limb
Oh, distal
Distal convoluted tubule. Find that one. It's kind of towards the right side.
Oh,
You see
yeah.
the distal convoluted tubule right there?
Is it number 4?
Yeah. So if you look down, there's a key down at the bottom, number 4. That's where the thiazides work. Okay, so you can also write it up there if you want to. It's just the key. And you can see that that's where sodium and chloride are typically reabsorbed, but the thiazides are going to block that. So what follows salt? Water. So if it's blocking the reabsorption, the sodium goes out. What's it pulling with it? Water. Okay. It is ineffective if the GFR is less than 20. What's a normal GFR?
125.
Yeah. So a GFR of 20, that's bad. So do you think you're going to throw a weak ass diuretic at a GFR of 20? It won't work. Like, that's a joke. Okay. It may cause lithium toxicity. Does anybody know anything about lithium? I need y'all to make a little cheat sheet for yourself because you're going to have this in psych and you're going to need this for NCLEX. Okay. Lithium is a drug that we use for bipolar and it's very tested on drug. It's a very tested on drug. Lithium has to bind to salt to be excreted. So it has to desperately find a salt molecule to bind onto to get peed out. Okay. Y'all know I always ask you for keywords with things, right? So lithium has 2 keywords, kidneys and salt. Kidneys and salt. So anytime I ask you what's lithium's keywords, you're going to say, so where is it excreted? In the kidneys. What does it need to be excreted? Salt. Okay. So with lithium, they'll always tell your lithium patients, make sure you take in enough salts. They won't say high salt diet because people will go for it and like just eat a salt lick, but they'll say, make sure you take in enough salt. Why would you tell somebody that? They can go into toxicity because lithium requires salt to be bound for it to be excreted. Okay. So lithium is kidney, and this is also kidney, right? HCTZ. You with me? If we said that HCTZ causes you to pee out your salts, yep, then what happens? What does lithium need to be excreted? Salt. So if they're taking HCTZ and lithium together, HCTZ is getting rid of all the patient's salt. What's going to happen? Y'all stop. Okay, let me start it. Okay. HCTZ makes you pee out your salt, correct? Okay. So yes, the patient will go into hyponatremia, but that's because of the HCTZ. What does lithium need to be excreted? Salt. You don't have any salts. So lithium can't be excreted. So if you're on HCTZ plus lithium, you can go into lithium toxicity. And remember, I told y'all last time, but if you need to write it down and get on another cheat sheet, write it down. What 3 things have the same level, 0.8 to 1.2? Yeah, we did this last time.
The
Creatinine. This one. Lithium. And a drug we're going to learn today. It's a heart drug that starts with a D. Y'all have heard of it before. Because we talked about it a lot in pharmacokinetics. It's a drug for heart failure. Starts with a D. Ends with a digoxin. Digoxin. Good. Those 3 have the same levels. Okay. Y'all with me? 0.8 to 1.2. All right. So do you understand why a patient on HCTZ may go into lithium toxicity? Yes? Okay. So side effects of HCTZ, hypotension. We already saw that coming, right? Okay. Now remember, the kidney can filter a lot, right? And a lot of molecules will come out. But if it's busy doing something in one section, the other stuff that's supposed to come out the kidneys will not. Okay. Especially the big molecules. So look at the next one that says hyperlipidemia. What's lipids? Fats. Big molecule or small? Big. It's big. So if the kidney is working on doing all of this other stuff, it's not going to be able to get rid of any fat. So they may get hyperlipidemia. Okay. No, I'm going to hold on to the hypercalcemia for just a minute. All right, let's go to adverse effects. Why might they have hyponatremia?
Because it's getting excreted from the hydrochlorothiazide.
Yeah, HCTZ gets rid of salt, right? So that makes sense that you'd have hyponatremia. What piggybacks onto salt? Like a chloride. So again, we're going to have hypochloremia. Dehydration is a given, right? Because it makes you pee. Hypokalemia, that's a given because potassium is excreted by the kidneys. So it's going to pick up that potassium on the way. Now, sugar, big or small molecule? That's a big molecule. So it's not going to allow the sugar to come out. So they may get hyperglycemia. What is uric acid? Where is it excreted? It's broken down in the liver into urea, and then it goes to the kidneys. But if the kidneys are busy doing other things, they can't get rid of the uric acid. What disease can come about from hyperuricemia? They can get gout, okay? And then hypomagnesemia. Now, your kidney doesn't usually just get rid of a bunch of mag, but your kidneys will always come through in the clutch. And when it picks up all these other electrolytes, the mag will come through with it. So they may also get hypomagnesemia. What goes on a seesaw with magnesium in the muscle?
Calcium?
Yes. So if they have hypomagnesemia, they will get hypercalcemia. Aren't you glad you learned a seesaw?
So
all right.
Are we going to insinuate there's hypercalcemia
Do what?
here?
No, it's on side effects.
Okay. Oh, never mind.
Yeah. All right. So nursing care, we're going to encourage them to eat high potassium foods. We don't lose potassium. Okay. We're going to monitor their BP. What might I expect on HCTZ? They might have low blood pressure, so I need to watch it. What's the protocol for holding HCTZ? 90 over 60. We're going to watch an FLP. What's an FLP? Fasting lipid panel, because hydrochlorothiazide can cause hyperlipidemia. We're going to watch their calcium, mag, sodium, potassium. Then I wrote mag again because I was really interested in it. And their uric acid because it can mess up our levels. Yes? Daily weight, urine output. Now, why are we monitoring for digoxin tox? Oh, y'all don't know yet. Let me tell you. What did I tell you guys about lithium? First of all, what were your two keywords? Kidney and salt. And what did I tell you about salt and lithium?
Oh, they have similar levels with
They do have similar levels. And what is lithium? What is the salt? Lithium has to attach to salt in order to be excreted. In that exact same way, remember I told you it's the same levels as dig, but digoxin has to bind to potassium to be excreted. So if HCTZ causes your potassium to go, you can go into dig tox. So you also have to be careful with dig. Is this making sense? Okay. We do not use HCTZ in pregnancy or breastfeeding. Obviously, this is a lot of problems. We're just not. Nope. Okay. That's just a no-go. All right. Do we understand HCTZ? If y'all's patho was not so good, that would have been really tough. Y'all did really good. Do you get it? Okay. All right. Next, let's go to our potassium sparing. What does potassium sparing mean?
The potassium doesn't go get excreted.
Yeah, the potassium doesn't get excreted. So instead of it causing hypokalemia, it can cause hyperkalemia. Very important for you to know what's happening to your potassium. And your potassium sparing is called spironolactone. You can't mess that one up. Okay. It is weak, still not as, it's just still kind of weak. Okay. It's used as an adjunct drug. What's an adjunct drug mean?
Like the companies with another.
Yes, added on. So remember in we haven't done that yet. In drug therapy, you always add to, not take away. So if one drug isn't working or isn't working as well as we'd like it to, we add another one. So wouldn't it make sense if they were on HCTZ and it was working, but it wasn't lowering their blood pressure enough, we add spironolactone. Then it will have the opposite effect on their potassium, and that will actually help because one causes hypo and one causes, so it will even it out. So these will be great to give together. You with? So we add spironolactone to our potassium wasting diuretics so that way we can kind of even out their potassium as well. Okay. Now, how is it potassium sparing? Let's look at it. So it blocks aldosterone. What's the job of aldosterone? And water and sodium. So aldosterone holds on to water and sodium, but if it's blocking that, then what is it doing? You're peeing water and sodium. And then what goes on a seesaw with sodium? Seesaw. Potassium. So that's how your sodium is going to go way down, which means your potassium is going to go up. Do we understand? That's so fun. Okay, so side effects. Hypotension's a given, right? It's a diuretic. Okay. What is aldosterone? Like, what is it? I know what it does, but what is it? It's a hormone. So you're going to get, this is why I put a little thing around these. Okay. Hormonal effects like gynecomastia. What's that? Man boobs, amenorrhea, no periods in women, impotence. Who did this? So inability to get an erection. Yes, yes, good, good. And then hirsutism. You get hairy, like hairs will grow. So you can see why there's hormonal effects. Yes. All right. And we understand why the hyperkalemia with spironolactone. Yeah. Okay. So it can take up to 48 hours to see an effect. So don't be popping these over and over again thinking like, oh, my blood pressure hasn't lowered yet. Well, you stop. Give it a minute. Okay. Watch their EKG. Watch their potassium. We do not give potassium-sparing diuretics with ACE inhibitors because we haven't gotten there yet. But ACE inhibitors also cause hyperkalemia. Okay. No salt substitutes when you're on spironolactone. What are salt substitutes? Mrs. Dash. So it's meant for heart failure patients who can't have salt but still want some seasoning. But that seasoning is made of potassium. So now a lot of heart failure patients may be on this, right? And they're supposed to have low salt, so they'll recommend Mrs. Dash or salt substitutes. But in this one only, they cannot have salt substitutes. Now, if they were on HCTZ, could they have salt substitutes? Yes, because we want more potassium for that patient. Okay. Do we understand the potassium-sparing spironolactone? Y'all know I don't have a list, but I'll always give you you got this. Okay. All right. Next one is a loop diuretic. Oh, sorry. Did we look at did you look at your sheet first?
No.
All right, so let's go back. Potassium-sparing spironolactone. So it's in the distal nephron. Distal nephron. Number 5, way on the right side. See where aldosterone? Yeah, so that's number 5. That's going to be your spironolactone or your potassium-sparing. Got it? All right, the next one is a loop diuretic. Guess where these work? The loop of Henle down at the bottom. Okay, so it's going to work in the loop of Henle, and this is Lasix. So Lasix is a loop diuretic that works in the loop of Henle. Okay, but the actual name of it is furosemide. Furosemide, that's Lasix. And she's like, oh, I didn't know that. Yeah, so furosemide is Lasix. This one is very strong. Okay, it's a very hard-hitting kidney drug, which means it's also ototoxic, kidneys and ears. So what should you report? Tonight. Very good. All right, it comes PO, IV, IM. You can give this any which way you want to. Give it first thing in the morning. So what happens if you give Lasix at nighttime? They're going to be up peeing all night. And the night nurse is going to, oh my gosh, chew you up and spit you out. Okay. You can give it IV push. You can push Lasix. Do you want me to call it Lasix or furosemide? Furosemide. Okay. So you can push furosemide IV push, but you have to give it over at least 2 minutes because it's very strong. What happens if I slammed it? Where did all my fluid go? To my kidneys. You think your kidneys can handle a shit ton of fluid at one time? They'll shut down. Yeah, you'll go into full circulatory collapse. Like your blood pressure will be like 1/2. Okay. Yeah, this is not good. You cannot, it has to be pushed over at least 2 minutes. You with? All right. So how does it actually work? It blocks the reabsorption of sodium and chloride in the loop of Henle. So reabsorption means to hold in. If it blocks that, then it's going to let out. So it lets out the salts, and what follows salts? And water, chlorine and water. All right. May cause lithium toxicity. Can someone please explain why this would cause lithium toxicity? Okay, so you said lithium's keywords are kidneys and salt, but how would that cause lithium toxicity?
Because lithium is known to bind to salt to leave.
All right, so lithium has to bind to salt to be excreted, and furosemide causes
the
sodium to leave. It causes hyponatremia. All right, we got it now? Cool. All right, side effects you're going to see very similar to HCTZ. Hyperglycemia, hyperuricemia, hyperlipidemia, hypomagnesemia. Now, this one is so strong that it also pulls the calcium with it. Now, I want you to note that because in HCTZ, it caused hypercalcemia, but in furosemide, it causes hypocalcemia because it's so strong, it pulls out calcium with it. Okay. You're going to see the same over here. Hyponatremia, hypochloremia, dehydration. All of those were the same. Okay. And they do not know why, but furosemide can cause thrombosis or embolism, which is a blood clot. So you just have to watch patients for that. Okay. Because it causes hypokalemia, you have to watch for dysrhythmias, right? We already knew it was ototoxic because kidneys and ears. So monitor for tinnitus. And if you push it too fast, it will cause full circulatory collapse, meaning your blood pressure will literally tank to nothing because you made them pee out all their fluid. You drained their entire body is what you did, okay? All right, teach the patients how to take their own blood pressure because everybody's on furosemide at home. Watch the EKG, encourage high potassium foods. This is all sounding very similar, right? To HCTZ. Watch their blood pressure, fasting lipid panel, sodium, potassium, blah, blah, blah. Yeah?
Yes.
We're going to put them on fall precautions because it is very strong, which means they can feel dizzy because it lowers their blood pressure quickly. Oh, look at me really quick. That's very important. In every drug that I give you today, you will pick NA-select that apply to change position slowly. Anytime a drug affects your blood pressure, it can make you dizzy if you come up very quickly. You will always pick that NA-select that apply. Always. Okay. We do not give furosemide with NSAIDs. Why do we not give furosemide with NSAIDs? What is Magic Dana?
Kidney toxic.
Oh, well, house bells. You see how that came back to help you? So we know that NSAIDs can be kidney toxic and furosemide is very hard on the kidneys. We wouldn't want to give those two together. But you're also right. I want to go back to what you said. NSAIDs do cause fluid retention and that would just kind of cancel each other out as well, right? All right. Do we understand loop diuretics or furosemide? You okay?
I forgot to leave I left my roommate's dog outside.
Oh no.
She just got there because she likes to sit in the patio. And she was like crying. I was like, okay. So before I left.
You left her out and then you just forgot to bring her back in. Is she mad?
She was like,
Oh.
I
Do you need a minute?
No.
Okay. All right. So now we got the black line across, which means totally new ballgame. Okay. We have got this osmotic diuretic. Osmotic. What does osmosis mean?
Water.
Like the way that water diffuses, the way the water flows. Okay. It is very weak, and this is used for your brain only. It is called mannitol. What is mannitol used for? Brain. Mannitol. Brain. Mannitol. Brain. Mannitol. Brain. Good. So all it does is pull fluid off your brain. That's all it can do. It is not used for the rest of your body. You with me? Okay. So that's why we use it for increased ICP. What's ICP? Intracranial pressure. We can use it for increased IOP, intraocular pressure, because mannitol pulls fluid off the face and the brain, basically here. But it pulls it from here to right here. So what do you think the side effects are going to be? It brings the fluid from here to here. Crackles, pulmonary edema. Yes, they can get fluid in the chest. Okay. It is IV only. It is used in dire situations where the patient's brain is swelling or they got hydrocephalus or they got a ton of fluid up in their brain. You with me? All right. It inhibits passive reabsorption of water by osmosis in the PCT. Where's the PCT or what is the PCT? Proximal convoluted tubule. Find that one. It's going to be close to the beginning because proximal means close. Y'all see it? Right next to the glomerulus? Okay. So that's a proximal convoluted tubule, and that's where your osmotic diuretics are going to work. See number 2? Sugars, amino acids, sodium. All right. So side effects. Headache. Yeah, I think they already had that because their brain was swollen. But okay, whatever. Go off with yourself. Nausea, vomiting would make sense because we're pulling fluid from here to right here. And you can kind of, edema makes sense. They're going to have edema up here. Yes. Especially pulmonary edema. What's your red flag sign and symptom for pulmonary edema? Like if you see this symptom, you're like, oh shit, that's pulmonary edema and you better report that. No. Y'all, no. I know. Y'all were like, well, we really thought we nailed it. It's the big red flag for the respiratory system. It's like rigid board-like abdomen of the GI system. Okay. It's a color, first of all. It's my favorite color, obviously. How is my favorite color purple? Do you see purple anywhere in here? Y'all, what do you think my freaking favorite color is? Pink. Okay. Pink frothy sputum. Did you say urine? Ma'am. Okay. Pink frothy sputum. If you ever see pink frothy sputum, that is your priority in your patient. That means their lungs are filling up with fluid and they are going to drown on the inside. It's pink because you get pulmonary hypertension, meaning you got a lot of blood flow in the pulmonary vessels. Anytime you change pressure in a vessel, your body says something is wrong and you leak into the third space. But because there's so much blood in there, it forcefully pushes it and becomes mixed with fluid. So it's blood and fluid mixed together. So red and white mixed together makes a pink color. Okay. So, and then it can cause CHF because I pulled the fluid from Got it? Yes? All right. It's really weird how you have to give this. Remember, we're only giving it IV, right? It's it comes like it looks oily, kind of. So you have to put it in warm water first to kind of dissolve it, right?
Okay.
And so then you have to allow it to cool because obviously I'm not going to give like hot fluid into somebody's IV. But watch out because it can crystallize if it gets too cool. So you want it like right in the middle. Okay. If it's too hot, it will burn. If it's too cold, it'll crystallize. Have you ever like poured out honey and like you obviously don't want to eat like hot honey, that would burn, right? But if you leave honey somewhere for a long time, it forms the crystals because it gets too cold. Did y'all know that? Okay, so I make like this homemade cough syrup. It's got like onion juice, which sounds gross, and honey. And I made it like a couple of months ago. It's supposed to like stay, but I pulled it out and the whole bottom is nothing but sugar because over time when things cool, they will crystallize like that. Okay. Daily weight, urine output, we already saw that coming, right? Obviously, you're gonna want to give it slowly because what happens if I drain all of the blood off of your head at one time? You would be deceased. And yes. So we would probably give it slowly. And all your diuretics, y'all know you're going to give slowly. That would make more sense, right? Report crackles and edema. What does that tell me? We's drowning somewhere in here, right? All right. Do we understand mannitol? All right.